The Trump budget megabill is law. Drastic cuts to Medicaid will affect everyone, whether you have Medicaid or not. Welcome to Care Talk, where we talk about how healthcare works or doesn't work in America and answer your health insurance and healthcare questions. I'm Laura Packard, cancer survivor and healthcare advocate, here to help you. Please text or call in your questions at 202-838-6837, and we'll answer them in future episodes. Be sure to subscribe to my channel or podcast wherever you get your podcasts to get next week's show. In today's episode, healthcare expert Dr. Eric Fethke tells us more about how it will change all of our healthcare. So, welcome, Dr. Eric Fethke from Doctors for America and the Pursuit of Health podcast. Welcome, Doctor.
Hello, thank you for asking me to join you. It's an honor.
So one of the things we want to hear about is how will this bill affect patients, which you may see in your own practice?
Well, I think that really is the ground level question here. And I think there'll be phases at which we will all share with you in a moment a story of one of my patients, which I recently saw, and I think brings to light a lot of the issues that this whole issue will now raise. The broad question, though, is I think patients at first are becoming very startled and very confused. It was already a very confusing system, even for someone who is involved in the policy issues like myself and others, yet alone for patients. And I think this will just make it more confusing initially, especially whether or not people will be able to maintain their Medicaid insurance or coverage or not, or what their other options are. And I think for the states that are going to deal with this, everybody's going to scramble to try to make sure that they meet the requirements, new computer systems, and other ways to keep up with all the requirements that are now going to be monthly in order for patients to be on Medicaid. So that's going to take a while as well. But I would like to share an anecdote of a patient of mine, which I think really illustrates what's going to be happening, if that's all right with you.
Absolutely.
Well, it's fascinating. Timing is everything. But about a couple weeks ago, a patient of mine came in. She's now 22 years old, and she is finishing her last year of college. She remarkably survived a critical valve condition as an infant and had to undergo a life-saving procedure through a catheterization as an infant. Now, that lasted for about 11 years, and at 11 years old, she required surgery to replace that valve and did fairly well, but she does need medications, and her heart's not perfect, but it's pretty good. She remarkably, after all that, has been able to go to college and will be completing college next year. What is concerning is that her father is in the military under TRICARE insurance, and that will expire within the year at 23 years old, believe it or not. She will no longer be able to be under his insurance unless she pays $300 and some a month, which is exorbitant for that. And coming out of college, typically before all of this, someone would be able to get Medicaid as an interim bridge while they looked for a job. Well, the family is moving down to a state that has not expanded Medicaid, and therefore Medicaid is not an option for her, one of the 10 states, if she moves with her family. Now, she plans to do so because her mother has a chronic medical condition, and she actually will need to help her get through this. So where she's going to go, she may or may not be able to find a job that fits her degree. She will have to help her mom, and she will be out of work. And with the new work requirements, in addition to being in a state that does not provide Medicaid coverage for a young person who is otherwise able-bodied and is not a parent of their own caring for a child, she will not really have the options to be on Medicaid at this time. And she will have to, if she wanted to be, even if she was in the state that did have Medicaid expansion and therefore allow her to do so, she would have to work under the new work requirements and may not be able to get a job right away. So her only options would be to move out of a state that is non-expansion, which is where her parents have built their retirement home now, they would change everything. Or she would have to claim disability, which I have advised that she not do because of the future concerns about being disabled and all the work she's done to be not disabled. She would have to have a child, which may not be safe in her heart condition, and declare that she is, responsible for that child. Or the family would have to move. Ultimately, if they do stay where she is, her parents may have to pay for all her medical bills, and hopefully they can do so in their retirement after his long career of service to all of us in the military. And if not, without her medication, she could get quite sick and obviously not work and meet work requirements. So this is a very tangled web.
Hmm. Now, as a doctor, tell us about how these cuts to Medicaid and the Affordable Care Act are going to affect everybody, whether or not they have Medicaid or the ACA for their insurance. So tell us about that.
Well, that's a very interesting question because I think the biggest issue, these cuts will not directly affect those people who will be in private insurance and can work. It will not affect my patients who can be qualified for Medicaid in states where that is a requirement, other than that they will now have to either work 80 hours a month. They will have to be caring for someone else, like an elderly parent or a family member in their need. They'll have to claim some disability on their own, or they will have to have be a parent who is required to watch their child. These are the new requirements. And what's a catch-22 is, in order to be on Medicaid, you have to kind of be poor enough to be on Medicaid. Basically, you have to be in those expansion states making below $20,800, which is 138% of Medicaid, in order to qualify. So you have to work, but you can't make too much money. If you're in a state that's not expansion, that's not even an option at that level. If you wanted to get on in a non-expansion state the ACA requirements, you could do so if you made above 100% of poverty, which is $15,000, but you can't get on Medicaid. And so unless you do that, you're in what they call the gap, which means you can't get any insurance in the non-expansion state. So this is getting very, very complicated for people, much more complicated, making it harder to access care of any type, insurance levels. And a lot of people will get confused. The paperwork will be monthly. People will have to report regularly. The states will have to have systems that will work and be robust enough to keep up with all this reporting. And if not, people will fall through the gaps, which is where they estimate that several million people, up to 7 to 11 million people in many estimates, will fall out of insurance. They will not be able to take care of themselves. Many of them will get sick. They won't be able to work. And the whole system will have to pay for this in some form. Lack of employment, lack of productivity, lack of tax revenues, and other features of this bill that will really put the states under a lot of pressure. In some ways, it's kind of the Achilles heel of the healthcare system that they've tapped into. And the whole system will start to erode in terms of quality, equity, and other problems. But for individual patients of mine, it will initially become very confusing, frightening, and then many of them will fall off of insurance altogether.
Hmm. Cuts to Medicaid will close some hospitals too, though, which affects everybody, right?
Absolutely. Rural areas will be most affected, and areas we're about an hour north of the city here. But the most vulnerable sites will be areas where the rural hospitals really depend on these Medicaid revenues for patients that have been funded by the state. Everyone has to remember this is a partnership between the states and the federal government. And so when the federal government pulls out huge amounts of money, it will really hurt areas that were essentially depending on that. And hospitals will close. The distance between hospitals for care, especially specialized care like those that my patients receive, will be even harder to access. And this will ultimately filter down. All of us will somehow pay for this. Our premiums will go up in those areas. Our hospitals, even if it wasn't us that had Medicaid, if that hospital is closed, it still affects us. And ultimately, those around us, it's a moral question, I really believe. It's a human question. Medicaid was created in the 1960s, and it was created as a way for medical assistance. It was not supposed to be tied to employment. It was medical assistance. So that kind of goes along against the spirit of all of this. The other issue is that if that law basically creates so many people that are now unable to access care and really leaves a lot of people abandoned, that's actually considered unlawful unless you have some other alternative to provide that care. So it goes against the Medicaid Act on a legal basis, and there will be a lot of revenue spent in fighting this in the legal avenues. The way I see this, it's like food. If we had a bunch of people that we thought that the best way to help them get better, healthier, and be productive people in our society was to provide food subsidies and farming subsidies. And all of a sudden we said, well, those farms are out there, but we're going to make it very hard or impossible for you to access this. And we're not going to give you any other alternative. People would think that doesn't make any sense from a human and ethics standpoint. That's essentially what we're doing with healthcare here.
Hmm. And do you think insurance rates will also rise for everyone as people drop out of the Affordable Care Act because they can't afford it anymore?
Absolutely. I think that as this starts to weaken the whole system, your point is well taken. As the boat sinks, as one of my guests said, mentioned on my podcast, we won't see the tide rise and everybody get better. We'll see us all start to sink. This will filter down. There's no way that the system can hold back and have the states support this kind of revenue withdrawal from the federal government without sacrificing other areas in education and other services that they've provided. They're going to have to shift, or they're going to have to swallow this somehow. It's going to have to come through charity or some other means. And ultimately, that dollar will filter out, and the rest of us will have to pay for it in our own subsidies, in our own insurances. The system just can't hold the hospitals and the doctors, the nurses, those who provide it, if we lose that much revenue. We have to remember Medicare covers about 68 million people, Medicaid about 78 million people, including almost 8 million children. You can't just start to pull away $1 trillion, which is what this bill will do, from that system over 10 years and not see the effects. The other thing is, I also think we're spending money in the wrong place. If you looked at obesity, diabetes, and heart conditions, that's $1.2 trillion a year that costs our system. If we put money there, in 1 year, we would save what they're trying to save with this $1.1 trillion over 10 years. So I think we're also hurting the system that could create primary care and prevent the problems that are costing us the most money. So that's another feature of this. We're going to actually hurt a lot of patients by causing the problems that are hurting us most economically and costing us the most not to have primary care and preventative access. So this system just doesn't make sense. Ultimately, that will also cost us.
Thank you so much for joining us, Dr. Eric Fethke. How can people find your podcast?
Well, we are now in the 4th year of our podcast. And as you know, Laura, this is a venture of love in many ways and something we do with passion. Our podcast is on all formats. It's the Pursuit of Health podcast. And we talk a lot of the policy issues with guests that many of us probably share, but we focus on what the general public should know, could know, to be advocates and ultimately be boots on the ground to be aware of many of these same issues and join us as partners in healthcare providers, but also those who receive care, so that we together can be aware and address some of these issues. Advocacy cannot be done by health professionals alone, and we believe on the podcast that healthcare belongs to everyone. So there, and in my book, The Privilege of Caring, we talk a lot about these issues. So thank you for giving us the opportunity to address this. Also, people should know that Doctors for America, which is where I am a member, and really is a collection of physicians, thousands of physicians who really do care about these issues and want to make sure that the public realizes that we are fighting behind the scenes and in front of the scenes to address these issues that hurt everyone and we believe are particularly dangerous, and show a side of America that we don't believe is the best aspects of who we are.
Thank you so much. And now we're going to answer some viewer questions with Louise Norris from healthinsurance.org and Diane Archer from Just Care and Social Security Works. So let's start with what's been happening on healthcare from the administration recently. So, welcome, Diane Archer.
Thank you, Laura. So I wanted to talk about a little discussed provision in the Trump tax bill. We all know that the Congressional Budget Office projects that 17 million people will lose their health insurance. But what many people don't know is that there's also a provision which could drive up your drug costs if you have Medicare. It limits Medicare drug price negotiation. It's a gift to the pharmaceutical industry. So just to back up for a second, the Inflation Reduction Act, which became law a few years ago during the Biden administration, lifted a legal provision forbidding Medicare to negotiate drug prices. And as a result of the Inflation Reduction Act, Medicare has been negotiating drug prices on some of the highest cost drugs that people with Medicare use. And you will see beginning in 2026, if you have Medicare, negotiated drug prices, lower drug prices on 10 very high cost drugs. And then again in 2027, I think it's another 15 high cost drugs. But in 2028, there's going to be a narrowing of the number of drugs and the kinds of drugs that will have their prices negotiated as a result of the Trump tax bill. It excludes from drug price negotiation some drugs that treat rare diseases, such as certain cancers. These drugs tend to be extremely expensive, and the Republicans in Congress and President Trump have decided to allow the pharmaceutical industry to continue to charge exorbitant prices for these drugs. According to the Congressional Budget Office, when it comes to drugs, the Trump tax bill hands drug companies nearly $5 billion over the next 10 years, while costing people with Medicare more for their drugs.
Thank you, Diane. And we had a question last week that a viewer wanted to know about whether there would be lawsuits. And the answer is yes, that Planned Parenthood is the first to sue about healthcare provisions in the big ugly bill, but they certainly will not be the last. So expect a lot more lawsuits about every part of this bill. And the courts may strike down some parts of it. We shall see. There is some news about Affordable Care Act enrollment changes and lawsuits. So welcome, Louise Norris from healthinsurance.org.
Thank you, Laura. Yes, so this is an issue that we talked about a few weeks ago on this show, the new marketplace rules that were finalized by HHS in late June. And it does get kind of tricky to keep all these things separate, but this is separate from the budget bill that was enacted on the 4th of July. So the marketplace rules, this is things like in the fall of 2026, the open enrollment period is going to get shorter. It'll end December 15th in most states. Some provisions start almost right away. Next month, for example, DACA recipients will all get kicked off their marketplace coverage. The low income special enrollment period will end starting August 25th and then going all the way through the end of 2026. There's going to be increased requirements for documentation in order to qualify for subsidies or to qualify for a special enrollment period. So basically there's just, they're making some people ineligible for coverage and making it harder to enroll and qualify for assistance in the marketplace. And some mayors of a few cities, the mayor of Chicago, Baltimore, and Columbus, they have filed a lawsuit to block in an effort to block these changes, because the ultimate effect of all of these marketplace rule changes is it could be almost 2 million people, so somewhere between 1 million and 2 million people losing their coverage. And this is in addition to all the people who will lose coverage through the budget bill that was enacted. And it's also in addition to all the people who will lose coverage when the marketplace subsidy enhancements expire at the end of this year. So there are a lot of different fronts where this is happening in terms of changes that are going to make it just in general harder for people to obtain and afford health coverage. So that lawsuit is one to watch if you're paying attention to these marketplace rule changes that those mayors have filed.
Thank you, Louise. And then we had a lot more viewer questions from our last episode where we mentioned that traditional Medicare may be going through prior authorization in a few states for a few different procedures. So Kathleen wanted to know what are the states that will be using prior authorization for traditional Medicaid, and so did Barb. So Diane, can you tell us a little bit more about who should be paying attention to this in which states?
Sure. So just again to say this is a pilot project. It hasn't launched and it may never launch. It is flawed in many regards. It's also very limited. It's limited to Arizona, New Jersey, Ohio, Oklahoma, Texas, and Washington State. Those are the 6 states, but then it's also limited to 17 services, at least initially, that the government believes are susceptible to fraud, waste, and abuse. And so those services could be skin and tissue substitutes, electrical nerve stimulator implants, or knee arthroscopy for osteoarthritis. They're not necessarily the most commonly provided services. So again, very narrow. It's nothing like Medicare Advantage, where prior authorization is used all the time for just about everyone who is in the Medicare Advantage program. I think it works out to 1.5 prior authorizations for each person enrolled or something like that, millions and millions and millions of prior authorizations. Here it's very narrow. And I also want to say that in theory, prior authorization can prevent the delivery of unnecessary service, and that is a good thing. And so if the model were designed well to prevent the delivery of unneeded care, that would bring down healthcare costs and protect people. But the model as designed is flawed and we believe shouldn't go forward. And there is a push to prevent it from going forward. And here are a couple of reasons why there's this push. Right now, it looks as if the model is designed to engage the same companies that are delivering prior authorization in Medicare Advantage to deliver prior authorization in traditional Medicare. And the problem there is that we know that in Medicare Advantage, according to the Office of the Inspector General at the Department of Health and Human Services, there is widespread and persistent inappropriate delays and denials of care and coverage as a result of prior authorization. So we don't think that these companies are necessarily the best companies to be delivering prior authorization in traditional Medicare. In addition, the way that the government intends to reimburse these companies is as a percentage of the money saved. And that's problematic because that gives these companies an incentive to deny care inappropriately, because the more money they deny, more care they deny, I should say, the more money they have in their pockets. And so that is a poor incentive structure and not a good reimbursement model. So we are focused on that as well. And in addition, we are concerned that there's little transparency in this program as it is currently designed, which means that we won't know whether prior authorization is being applied appropriately or inappropriately. So we are highlighting these flaws in the design of this pilot project and hope that the administration takes these design flaws to heart and reconsiders the model.
Thank you, Diane. Our next question is actually more of a comment from Robert, who believes that the $1 trillion of healthcare cuts will have no impact because he thinks that that will only affect people that are non-citizens. So, Louise, do you want to talk a little bit more about how they're just that's just not accurate?
Yeah, I mean, not only is that not accurate, it's almost exactly the opposite is true. So, Medicaid, there are very limited exceptions, but in general, Medicaid is only available if you are a lawfully present citizen who has been in the United States for at least 5 years. So, you are not just coming to the United States and qualifying for Medicaid, even if you're lawfully present here, even if you're going through all the immigration channels. And if you are an undocumented immigrant, federal funding cannot be used for your Medicaid, period. Um, so the people who are going to be losing Medicaid, these 10 12 million people who are expected to lose Medicaid, are American citizens, or they are long-term immigrants, people who've been here for a long time, working and contributing. These are the people who are going to lose Medicaid. It's not immigrants. It's certainly not undocumented immigrants, and it's not even recent immigrants. It's your fellow Americans who are going to lose their coverage. And as we talked about earlier in this episode, this has a trickle down effect on everybody, because if your local hospital closes because their Medicaid funding gets reduced, then that affects you regardless of what health coverage you have. You're now going to have to drive to the next closest hospital, which is going to be inundated by people coming from the areas where their hospitals have closed. If you're on private health insurance, your premiums are going to go up because the uncompensated care that the hospitals have to cover for all these newly uninsured people, that cost has to come from somewhere. It's going to get passed on to people who have private health insurance. So if you think that this is only going to affect non-citizens, you are definitely deluding yourself on this. This is going to affect Americans across the board pretty heavily.
Thank you, Louise. And also, I want to make a point of saying that if people don't have health insurance and so they wait until things are really dire before they go to get care, that is the most expensive care. That it is preventative is the very best option for medical care. But after that, getting something treated early is much cheaper than waiting until cancer has spread, the stroke effects have been more than 24 hours, etc. So delayed care costs everybody. And our final question is from James, who says that Trump did an executive order to force big pharma to lower its pricing to match European and Canadian pricing. This was a story a few months ago when Trump signed the executive order on pharmaceutical pricing. Did it not happen, or what happened with that executive order? Was there any effect, Diane?
Excellent question. And the answer is there was no effect. Nothing happened. It was words and a lot of sizzle and no steak, as some people would say. The president doesn't have the power to lower drug prices by executive order. But if he had wanted to keep drug prices in the US in line with other countries, he could have required or asked Congress, urged Congress to include provisions for drug price negotiation in the tax bill that Congress just passed. Savings from lower drug prices would have helped significantly to pay for tax cuts for the ultra rich. But Trump was focused on tax cuts for the ultra rich and not on lowering drug prices. In fact, as I mentioned earlier in the show, the president and the Republicans in Congress included provisions in the tax bill that save the pharmaceutical industry nearly $5 billion by narrowing the scope of Medicare drug price negotiation, and allows the drug companies to charge even more for certain of their drugs for people with Medicare. One thing that the president could easily do right now is open our borders to imports of prescription drugs from verified pharmacies around the world. You can order prescription drugs for your own personal use from verified pharmacies outside the US. You can check out prices at www.pharmacychecker.com. But at the very least, if the president wants us to be paying what other wealthy countries pay for their drugs, we should have an open border for drugs around the world, just as we do for food. And we have a Food and Drug Administration. Food flows and lower prices happen because of imports from abroad. And the same could be true of prescription drugs if we allowed that. And President Trump has the power to do that.
Thank you, Diane. And thank you, everybody, for joining us today to learn more about the Trump budget mega bill that just passed, H.R. 1, and its cuts to our healthcare. Please text or call in your health insurance and healthcare questions at 202-838-6837, and we'll answer them in future episodes. Join us next week for more on healthcare in America. Be sure to subscribe to my channel or podcast wherever you get your podcasts. My name is Laura Packard, and this is Care Talk.